My name is Neil Anglin, consultant cardiologist, and today I'm going to talk about syncope. So what is syncope? Syncope is a transient loss of consciousness due to hyperperfusion of the brain. When somebody presents with syncope, we need to decide, is it true syncope or is it something that's mimic syncope? Things that can mimic syncope include intoxication, hypoglycemia, epileptic seizures. These all cause reduced levels of consciousness, but isn't technically syncope. When somebody presents with syncope, we can try and, for the differential, we can try and split the causes of syncope into cardiogenic and non-cardiogenic causes. Because as a cardiologist, really, I'm interested in the cardiogenic causes and I can investigate that and manage it. However, it is important to know the non-cardiogenic causes of syncope. A very common cause of syncope is vasovagal syncope, and this can be situational as well. Situations that can cause a vasovagal episode include pain, micturition, defecation, cough syncope. Orthostatic hypotension can cause syncopal episodes, and carotid sinus syncope. Orthostatic hypotension can be caused by volume depletion, which include hemorrhage, vomiting, and diarrhea. And autonomic failure can be as a result of old age, Parkinsonism, diabetes, amyloidosis, spinal cord injury, and also drug induced with drugs such as vasodilators, diuretics, and antidepressants. So now if we move on to the cardiac causes of syncope, this includes arrhythmia, both bradyarrhythmias and tachyarrhythmias. Bradyarrhythmias include things like sinus bradycardia. It'd be quite unusual to have syncopal episodes with sinus bradycardia. I mean, if the patient was also hypovolemic, for example, that may contribute to a syncopal episode. But other bradyarrhythmias, including heart block, such as second-degree heart block, both Mobitz type 1 and Mobitz type 2, as well as complete heart block. Ventricular pauses can also cause syncopal episodes. With tachyarrhythmias, a sinus tachycardia doesn't usually cause syncopal episode. It may make patients feel a bit lightheaded or the sensation of palpitation, but it shouldn't really cause a syncopal episode. A narrow complex tachycardia, such as supraventricular tachycardia, may cause a syncopal episode as well as ventricular tachycardias. Structural abnormalities in the heart may also precipitate syncopal episodes. This includes aortic stenosis, hypertrophic cardiomyopathy, prostatic valve dysfunction, and myocardial infarction. Pathology of the great vessels may also precipitate syncope, which includes aortic dissection and pulmonary embolus. So if somebody presents with syncope, we need to really figure out why this happened. And the best way to figure this out is to take a good history. But the problem is, if someone has a syncopal episode, they can't really always tell you exactly what happened. They may be able to tell you what they were doing beforehand, but they may not be able to say exactly what happened during the time of the syncopal episode. Therefore, the key to taking history is to get a witness. So when somebody presents with syncope, one of the things you want to find out is what they were doing beforehand. For example, were they exerting themselves? Were they sat down? Were they laying in bed? Had they just stood up? If they just stood up from a seating position, then the syncope may have been precipitated by postural hypotension. If a witness, for example, said prior to the syncopal episode, the patient started having seizures or fit type movements and became urinary incontinent, then it's more likely an epileptic attack. It's important to know whether the syncopal episode was precipitated by exertion or whether with pain or for standing for prolonged periods of time. Standing for long periods of time and blacking out may be a result of a vasovagal episode. If the patient has a syncopal episode on standing, this is highly suggestive of postural hypotension. If the syncopal episode occurs when the patient's been moving their neck, this could be due to vertebrobacillar insufficiency or a carotid sinus hypersensitivity. When trying to investigate what causes syncope, the first thing we should do is do a lying and standing blood pressure. If there is a drop in blood pressure on standing, and this is highly suggestive of postural hypotension. When taking the blood pressure, the patient should be laying flat to take the initial blood pressure. They should stand and then a blood pressure should be immediately taken, and the patient should stand for a further at least 3 minutes and a further blood pressure taken to see if there's any postural drop. Another important investigation is an ECG. A 12-lead ECG will show what the underlying heart rhythm is. It also can suggest structural abnormalities of the heart and may also indicate things like long QT and Brugada syndrome, which again can predispose to cardiac arrhythmia. The key really here is to monitor the patient, monitor their heart rhythm in order to capture any arrhythmia. So what kind of monitors do we have? Well, we have bedside monitors where patients are literally wired up to a monitor at the bedside. This can record the ECG, but the problem with this is if they don't have any arrhythmia or syncopal episode caused by an arrhythmia during their inpatient stay, then this may never be captured on a monitor. We also have ambulatory cardiac monitors, but again, the question is how long do the patients wear the monitor for? Usually we put these monitors on for 24, 48 hours or even a week, but again, if they don't have a syncopal episode during this period of time, then we may never get to the underlying diagnosis. If, however, we are strongly suspicious of an arrhythmia and the frequency of the arrhythmia is very low or very infrequent, then we do have loop recorders, which is a device we implant under the skin under local anesthetic, which usually has a battery life of around 3 years, and we're literally waiting for another episode to occur, another syncopal episode to occur, and then the monitor can be analysed and to see whether an arrhythmia has been detected. The other advantage of having a loop recorder is that it can also pick up arrhythmias sometimes before the loss of consciousness occurs, and if that's the case, treatment can be started if this is picked up. Another investigation is an exercise tolerance test, especially if the arrhythmia is precipitated on exertion. And we also have a tilt table test, and this is really to try and precipitate a vasovagal event as a cause for the syncope. Another important investigation from a cardiac perspective is an echocardiogram. An echocardiogram will assess the heart's structure and function. If there is any abnormalities in the cardiac structure, including enlarged atria or ventricles, then this can predispose to arrhythmias. From the history, it's important to ask about a family history of unexplained syncope or blackouts, as certain cardiac conditions may run in families, such as hypertrophic cardiomyopathy, long QT syndrome, and Brugada syndrome. A very important aspect to discuss is driving restrictions. In the UK, if someone has unexplained syncope, they need to refrain from driving for a certain period of time, usually 6 months, if a cause has not been found. However, these rules do change from time to time, therefore it's important to find out what the latest guidelines are from the driving licensing authority in your area. Okay, so to summarize, syncope is a transient loss of consciousness due to hyperperfusion to the brain. There can be cardiac and non-cardiac causes. It's important to take a detailed history in order to try and find out the cause of the syncopal episode. It's also important to find a witness who can also give details of the history. There are a wide range of differential diagnoses, and there are a number of investigations that can be done in order to try and find out the cause of the syncopal event. Thank you for listening to my video. If you like this video, I'd be grateful for a thumbs up, and also if you want to hear more videos like this, please subscribe to my channel. Thank you very much. Bye bye.